So joining us tonight from Case Western University and the University Hospitals is Dr. Vic Kashyap as Professor of Surgery and Chief of Vascular Surgery and Endovascular Therapy, and his fellow, his second year vascular fellow, Christine So, who will be joining us also to present their articles. I'm going to try to share my screen one more time, and hopefully we can put everybody's picture back up. Joining us from UT Houston at McGovern Medical School is Dr. Naveed Sadiq, and also Tommaso, who is his fellow. He is his fourth year integrated fellow, and they will be talking about the FEVAR article. We have authors that are joining us as well. Dr. Fernando Mata, and who is the fourth year integrated vascular resident at Chapel Hill, and also Darren Schneider, who will be answering questions from their article. And then from the University of San Diego and Penn State, Dr. Malas, as well as Dr. Isaac Nazy, who have joined us before, and Dr. Ziali, who will be discussing their article or fielding questions about their article. Our two guest moderators are Dr. Kathleen Oswald, who is the Chief of Surgery and a Professor in Surgery at Albany Medical Center, and then Dr. Fazal Aziz, who is an Associate Professor of Surgery and the Chair of Surgery at Penn State Health, Heart, and Vascular Institute. Just some housekeeping things. In general, we ask people to stay muted. That happens most of the time. We ask you to put your questions and comments in the chat. At times, the moderator may call on you to come forward and speak about the questions or to voice your question. The event is being recorded for on-demand access. Portions of the event may be erased so that before we put it up on the web.
Yeah, that's a good idea.
Yeah, and finally, we'll be doing this again in September using the JVS, or the JVS Online Journal Club in September will be on the 16th at 8 p.m. Central Time. It's being hosted by the University of Chicago and also Good Samaritan Hospital in Cincinnati.
Can you folks hear me okay?
Sounds good, Vic.
Okay, thank you. Well, I want to just start by just apologizing on behalf of my other co-moderators and the folks that have organized this. I can't tell you the number of hours that Paul and Misty have devoted to making sure this is successful. It's embarrassing for me and it's embarrassing for all of them. So I apologize on their behalf and for all of us that are part of this. Really unforgivable for that to happen to us, and hopefully we can prevent that in the future. I do want to say on a brighter note, I know we're doing this over Zoom, and I wanted to start with some light comments saying that, boy, it's been a difficult couple of years. I've really gotten a chance to explore places around Ohio, especially the outdoors and doing social distancing, and I hope that you have as well, both nearby and down in the southern part of the state. And there really are some spectacular outdoor places, I'm sure, close to you as well. And I want to reassure everybody, there is a light at the end of the tunnel, and hopefully we'll have a new day coming in the future where we're doing this either live or in some way that is much more personal and meaningful. Dr. So, our very excellent senior fellow, is going to discuss this paper in detail. And I just want to start by congratulating the authors, Dr. Nazy and his co-authors, for really putting together a very thoughtful analysis on a problem that's tremendously important for all of us that take care of patients with peripheral vascular disease. And when you hear about the details and hear Dr. So's very thorough discussion, I want you to keep these couple of parameters in mind. And the first question I'd like you to keep on thinking about is, how do we define success in patients with CLTI? I think many of us think about resolution of symptoms or healing of ulcerated tissue, patency, preservation of limb, preservation of life. Those are things that we talk about in almost every paper that gets discussed. about peripheral arterial disease and revascularization. Something that's less talked about, but very important, I think, is functional improvement, resource utilization, cost effectiveness, and patient satisfaction. But this paper highlights something else. And I think there are other markers of success in CLTI, and we ought to think about those. How do we balance a patient's wishes with managing their expectations of outcome? How do we improve frailty, or can we? How do we predict the long-term outcome using accurate risk stratification? And how do we know when an intervention may be futile? So many of you may say, oh, Vic, we don't have a crystal ball. But I think this paper at least gives us a building block on how to look at these patients and maybe some more granular data on how to make decisions. So I will stop there and turn it over to my excellent senior fellow, Dr. So.
Thank you, Dr. Kashyap. Good evening, everyone. I'm Christine So. As Dr. Kashyap said, I'm one of Dr. Kashyap's second-year fellows here at University Hospitals in Case Western in Cleveland. We'll be discussing the impact of impaired ambulatory capacity and the outcomes of peripheral vascular interventions among patients with CLTI. So CLTI encompasses about 11.1% of all PAD, with an annual incidence of up to 3,500 cases per million US adults over 40. The real crux of the matter is that mortality is as high as 20% within 6 months of diagnosis, and this exceeds 50% within 5 years of diagnosis. So as Dr. Kashyap said, we have to take a look at the whole patient and what may be best for that patient. So global vascular guidelines have recommended consideration of primary amputation or palliation for some of these patients who have already limited life expectancy or poor functional status. Previous studies have shown that ambulatory status is a predictor of even the choice of revasc options that we offer to these patients, where those with impaired ambulatory status and more comorbidities are more likely to be offered peripheral vascular interventions as opposed to open lower extremity bypasses. In this paper, which was a retrospective review of the VQI database from September 2016 to December 2019, about 50,000 patients were studied over 4 separate cohorts, from ambulatory to ambulatory with assistance, wheelchair-bound, and bedridden patients, with the main objective to evaluate of how ambulatory status impacts the postoperative and long-term outcomes of PVI for CLTI patients. The primary outcome was 30-day mortality and 1-year amputation-free survival, with secondary outcomes of in-hospital death, postoperative complications, 1-year freedom from major amputation, and 2-year survival. Postoperative complications was a composite of cardiac, pulmonary, and renal complications. So MIs, new dysrhythmias, need for ventilation or vent support, PEs, elevation of creatinine of 0.5, or new need for hemodialysis. Demographics, just things to highlight, besides, our vascular population, greater than 50% of bedridden patients were from nursing homes. The bedridden category, there's a higher proportion of females and those from the Black population. And then those who are wheelchair bound were more likely to have had a prior amputation, bypass, or previous peripheral intervention. In terms of treatment type, 52% had more than one artery treated, and then POBA was the most common treatment type. So the juicy part, in terms of results, 30-day mortality, you can see a huge difference here, 1.3% 30-day mortality in just the ambulatory, and this goes all the way up to 9.3% in the bedridden patients. Post-op complication, 2.7 in ambulatory, and all the way up to 5.1% in the bedridden population. Twofold increase in the odds of 30-day death in patients who just ambulatory with assistance and wheelchair bound, and a 6-fold increase in those who are bedridden. And this, despite stratifying for CLTI stage, this association remained true. So alternatively, you can see 60% increase in odds of any postoperative complication in ambulatory with assistance patients, and all the way up to 77% increase in odds for bedridden patients. To weed things out a little bit for specifics, those with ambulatory with assistance had a significantly higher odds of cardiac, pulmonary, and renal complications compared to ambulatory patients, whereas the wheelchair bound had more pulmonary, renal, and bed bound threefold and twofold increases of pulmonary and renal complications. But pictures speak 1,000 words, as they say, right? Freedom from major amputation, you can see here. The lines show the significance there at 1 year. Freedom from amputation for ambulatory patients was 90% and all the way down to less than 70% in the bed-bound patients, which is the orange line at the bottom through each of these subsequent graphs. In the 2-year survival, the 2-year survival, 82% in the ambulatory patients, all the way less than 60% or 59.2 in the bed-bound. Alternatively, you can say risk of death within 2 years was 40% higher in the ambulatory with assistance versus 81% higher in wheelchair bound and greater than twofold increase higher risk in bed-bound patients. And then amputation-free survival at 1 year, there was a stepwise decrease with starting at an 81% risk at the, or 81% at 1 year and all the way down to less than 50% in the bedbound patient at 1 year. So what does this paper bring to the table? Again, as Dr. Kashyap mentioned, we have to figure out what our goal of each of our interventions are. Is our goal shifting rather than full limb salvage in these patients with multiple medical comorbidities and poor ambulatory status? Those who push for revascularization is a goal of eliminating rest pain or healing of ulcers. We know now that ambulatory status is associated with higher odds of mortality within 30 days. 2 things the paper highlights that I think we should keep with us is these 2 statements here, that non-ambulatory patients, specifically bedridden ones who undergo PVI for CLTI, end up with an amputation and or die within 1 year of their index procedure. And then even when a minimally invasive option is used, with those patients with impaired ambulation, perioperative mortality and adverse events are substantially high. So yes, it's a retrospective study. And yes, the ambulatory status is subjective. It was their best status over the month prior to entering the registry. And we don't have a record of wound score, so the severity of their tissue loss. But I do think that this shows that ambulatory status is another thing we have to take into strong consideration when we look at the whole patient and decide what treatment option we are going to offer our patient population and what is the best thing going forward for them long-term, not just the tissue or the wound or the obstacle at hand. Thank you.
This is Kathleen Osvat. That was a great job. I really enjoyed your slides and the way you put this together. There are several questions already in the chats. And I was wondering if maybe we can start with Dr. Aziz had a question for the authors. Is there a gross mismatch in sample size between comparison groups? And did you consider, did you consider performing propensity score matching to obtain comparable groups?
Hey guys, this is Mahmoud Malas. Just out of surgery, so sorry I can't turn my camera on yet, but Dr. Nazi is the first author and he is first. Thank you for hosting us. Yes, apology about all this madness at the beginning. Excellent presentation. Thank you, Vic. And the slides are really beautiful and really discuss the paper really nicely. So I'll let Isaac answer, and if give him the spotlight. And if there's anything else I can add, I'll be happy to add it. Go ahead, Isaac.
All right. Thank you very much, Dr. Malas, and thank you, Christine, for the nice presentation. To go straight to the point, so we had 4 comparison groups, as the presenter rightly pointed out, and to do propensity score matching, usually just 2 comparison groups. but they usually with propensity score matching, when you have sample sizes that are widely variant, it could help with adjusting for confounding, like with logistic regression as well. In this particular situation, we chose to go with the logistic regression, given the fact that we had 4 comparison groups, and it is better to do the multivariable logistic regression, which also addresses the confounding if you adjust for all relevant potential confounders. So we could go propensity score matching, but we'll have like several multiple analysis doing like 2x2 comparisons, and that would be a problem for a single paper.
Thank you for that answer. The next question from the audience came from Dr. Abai. How would the 2-year survival of the 4 groups rate in patients who do not undergo any procedure? Is there any way to normalize so that there's no bias?
Dr. Malas, I don't know what you want to
Yeah,
say.
so I mean, so that's, I mean, good question so far. So I mean, this is the most common thing we get on any paper we write. If we did not do propensity score matching, the reviewers, that's the first thing they ask. And it's not, I mean, people think that this is the best way to do analysis. It's not. And there are certain situations, if you study a statistic and go to school like Isaac did, and like I did also at Hopkins, you kind of figure out that, with propensity score, there's definitely an advantage, but you're going to lose large number of patients when you do propensity score, and then your sample size gets smaller when you already have 4 groups, and that minimizes the impact and of your analysis. And if you can adjust to the regression model, I don't think that's an inferior way of doing it. For the second questions, as far as what happened to the one didn't get operation, of course we can't answer that, because VQI is based on intervention, right? So only included are the patient who had an intervention. So it's a very good point, but within the limitation of VQI, we can only compare the people who had an intervention. But at any rate, just showing how the different ambulatory studies dramatically affected the outcome. I don't think it will change if we the conclusion of the study. If we really had the data on people who did not have an intervention at all, because the question is, should we really be intervening on people who are bedridden, and why are we intervening in the first place on people who are bedridden to save their limb that they're not going to use?
That's a great point. Do you know, or were you able to find out whether or not how many interventions were done at a given intervention? So in other words, was the SFA treated at the same time as the tibial vessels and so on? And was there a difference in the number of treatments per patient between the groups?
Thank you so much for the question. It's a great question. So that was really very difficult to tell from the database, but we're able to at least tell that for some patients, they underwent more than one procedure and more than one arteries were treated, and we presented that in the paper. Thank you.
Thank you. Are there any questions, other questions from the group?
Dr. Lawrence, do you want to unmute and ask your question? I think you're still muted.
I'm unmuted now. Yeah, I thought that the categories are important, but obviously there's a big difference between somebody who's, let's say, in a wheelchair simply because they've got an ischemic foot with a wound on their foot, and somebody who's been in a wheelchair for years. And I wonder how that should enter into it. So you move from one category to the other. Some patients, because of the ischemia, and other patients, it's because they live in that category for their whole life. So I'm curious as to how that should enter into decision making.
Isaac, you want to take that as far as how the definition within VQI is like when someone is non-ambulatory on the timing, how long. And so what Dr. Lawrence talking about is very important. So if someone we saw clinically and they were ambulatory until a couple of months ago and functional, and now they have a critical limb ischemia, and because of the critical limb ischemia, now they're wheelchair bound. And these are very different patients than the one that have been bed bound for 2 years. And so I think the way VQI categorize it, Isaac, you want to take that?
Yes, yeah, I'm sure, Dr. Malas. And thank you, Dr. Peter Lawrence, for the question. It's a very important question, and we actually proactively addressed it in the manuscript because we thought it was clinically relevant. So, like we said, the ambulatory status was more subjective, and it was the best ambulatory status in the mind prior to the procedure. And that is the only information we have from VQI as to the timing of ambulatory capacity. So patients who were temporarily ambulatory, probably because of ischemia, limb ischemia, we couldn't really tell for how long they were, maybe 1 month or 2 months. That wasn't really clear from the data sets. And it's a limitation we have admitted in the manuscript.
Dr. Mattis, I think your question is really kind of relevant, and I'd like to, if you're willing to ask it, go ahead and unmute yourself and ask it, because I think it's an important question.
Yeah, thanks, Misty. And very nice presentation, good paper, Mahmoud and Isaac. So the question I have is, as all these large patient studies is, how are we going to use this clinically to make a decision when they come into my office in a wheelchair or in a bed from the long-term patient care? There's a push now nationally by a lot of cardiologists that nobody gets an amputation before an angiogram. So the other question is, based on your data, which groups of these 4 shouldn't receive an angiogram or an intervention, but you should go to primary amputation? Because that's what we need to know, and clinically. So maybe you can answer that question. Thanks.
Yeah, I'll take that one, Isaac. But thank you, Peter. This is a very important question. And I mean, I always tell all my fellow, and for all the residents and fellows on the call, the purpose of doing this research is not just to write paper and publish and present in journal club, is to kind of try to find an important clinical question and find an answer that is clinically applicable that can improve the outcome of the patient. That's the whole purpose of VQI. And all the research we do with at least with the clinical research that we do. So to me is what it was very surprising to me to see that almost 20% of people that get in peripheral intervention are non-ambulatory. And I mean, that's a problem. And we always, vascular surgeon, we talk about inappropriate procedure and how cardiologists do these things that they're not supposed to be done. And then we look within our own data that it's mainly filled by vascular surgeon, and we find that 20% of patients are non-ambulatory. So, yes, there's gonna be a limitation, and there're gonna be some people who were ambulatory until this recent event with the critical ischemia. But clearly with this large number of patients, they have to be some patients, or many of them, that they've been non-ambulatory for a while. And I think what I take from this is, I mean, it's not really surprising, Peter. I mean, you and I, we're not gonna just go in and someone who's been in bed for 2 years, we're not gonna go in and try to salvage their limb that they're not using at all. So I think the clinical decision making is gonna be based on patient per patient. How long have they been non-ambulatory? Is it really because of their critical limb ischemia, or this is their baseline? And what are we trying to accomplish? If they're non-ambulatory, but these, they use their leg to get in out of bed, to get on the commode, and that's important to me and to the patient. It's huge. So we can't just say, okay, yeah, just wheelchair, let's just cut the leg off. I think the decision have to be made, informed based on what the patients are doing and whether they use their leg or not, and how are they using it. And then, we all know that people who are non-ambulatory, they do poorly with everything, any procedure they do. They're deconditioned and they don't do well with open surgery. And this is maybe one of the first studies to show that even, the notion that, well, but that's an angiogram. That's an angioplasty. That's minimally invasive procedure. It's okay to do it. And this just shows that it's not, because these patients still not really, benefiting from the procedure. And Society of Vascular Surgery guideline, we just published the carotid guidelines. For instance, in carotid, we say if you're not going to live 3 years, we should not be doing a carotid revascularization on an asymptomatic patient. The same thing with the peripheral. So we just have to make those decisions, I think, based on each patient. And the takeaway message is that these patients are not going to do well if they're truly bedridden for a long time.
Mahmoud, that's a great point. Can I ask a question? Did you do a sub-analysis by specialty or not? The reason why I ask is that, as you know, the cardiology registry is closing and they will become a part of VQI. And it certainly has implications for future because we will be seeing more and more interventional cardiology data to be included in VQI from here on.
Yeah, great point, Faisal. Thank you. And the short answer is no, we did not do that. And I think, we want the cardiologists to be part of VQI. And I think anytime we do a study and we try to alienate one specialty, I think that can have a bad, results. I just my own opinion, my humble opinion. If we go in and, a lot of the carotid studies that we do, when we stratify by specialty, we show, for instance, vascular surgeons have better outcome than neurosurgeons. We did that with CREST 2 and CREST 1, so CREST 2 and CREST 1 before. And we just don't publish that because it's just, I don't think it has a good, positive feedback. I mean, cardiologists are not going to stop doing procedures because we show their outcome is worse or they're doing stuff that is, especially if we want them to be part of the team, if we want them to join VQI. So I think we have to be very careful with VQI as we have more and more cardiologists joining, not to kind of alienate one group. That's my humble opinion.
I thought right now they won't give you that separation is one of the things that I thought is one of the limitations, and good or bad, that right now they won't give you that particular variable.
Yes.
They don't, but just like you can also, you can get, individual surgeon outcome that you can request it.
Yep.
And then it has to be approved, individually by every specialty or every surgeon, So that's why we usually don't ask for that, because that's very tedious and it takes forever.
There's another question here that I think is a good one to ask, and it was that podiatrists will tell people not to walk after toe surgery or whatever because of tissue loss issues and whatnot. Does that, do you think that might alter the way we should have them treat their patients, not keep them non-ambulatory, especially after an intervention?
Isaac, you want to take that? So I don't keep talking. This is your chance to chime.
Thank you, Dr. Malas, and thank you for the question. From what I gathered from the question, I think if someone is just, we know for sure the person is just temporarily non-ambulatory, that should not really count towards them being classified as non-ambulatory, especially if a podiatrist has recommended that the patient should not use a foot just for a specific short time. So in my opinion, I think that should not really count towards them not being them being non-ambulatory. But if Dr. Malas would like to add something else to it.
Yeah, no, I agree. I mean, absolutely. So, this whole analysis was done for their status prior to the procedure. And typically, like, if they have gangrene or issues, you revascularize them to get a toe amp by podiatry or by vascular surgery, and then you ask them not to move until that heals. That's totally different, post-operative course management. Then I don't think that counts into what we're trying to do here. We're talking about, like, you've seen the patient first time, they have critical limb ischemia. What happened in the last, several months to a year prior to your intervention? I mean, that's the first question I ask when I see someone with PAD. How much walking have you been doing? And, when did that change? So I think that's more for the post-operative. I don't think that will apply here.
I
Thank
think
you.
this generated a lot of great discussion. So, and thank you, Dr. Oswald, for moderating and going through all those questions. There are so many of them. In the interest of time, we are going to move on to the second article, which is the fenestrated branch endovascular aortic repair is safe and effective option for octogenarians in treating complex aortic aneurysms compared with non-octogenarians. And Navi, do you want to take that one away?
Yes. Can you see my slides?
We can.
Okay.
Okay, good.
Thank you. Well, first of all, I would like to thank Paul and Misty for all the hard work you've done throughout the year, and also especially for this one too. It takes many hours for you to go through articles, identify them, and also you're like arranging this whole conference is very commendable. And thank you for all the work you've done. And also, I'd like to thank Dr. Lawrence and Dr. Gulwiski for also putting a lot of efforts in it. Dr. Schneider and Dr. Mota, thank you for joining in today for being the authors for this excellent paper. And Dr. Aziz for being the moderator afterwards. I'll keep it brief, but I'm practicing in Houston where most of the work has been done for open thoracoabdominal aortic aneurysm, setting benchmark and outcomes there. But with the advent of endovascular treatments, you've seen increased use of them, and questions keep coming up because still the experiences in the start. The question, which was beautifully put forward by the authors, was what is the outcomes in patients who are octogenarians, who are going to be the ones who you expect to have more comorbid conditions and have higher complications. And if you can show good outcomes in them or safe outcomes, it could become a valuable alternative to open surgical treatments for the complex aortic aneurysms. And so the paper that has been chosen it's a non-randomized prospective study performed by surgeons who have IDEs, and they're combining all these the outcomes by using a variety of devices in juxtarenal, pararenal, extent 4, and extent 1 to 3 thoracoabdominal aortic aneurysms. And it'll be very interesting to see the methodology, the sites which were included and the papers. And I'll have Dr. Tommaso present it, and we'll have questions afterwards.
Thank you, Dr. Saqib, and thank you everybody for joining us tonight and setting this up. I'm going to be discussing this article based on outcomes of fenestrated and branch devices in octogenarians versus non-octogenarians. So as we know, with aging population in the USA, we have almost 15 million Americans above the age of 80 years old. So we see more and more octogenarians presenting with aortic aneurysms. And with increased age, we also see an increased prevalence of comorbidity. And also this patient population is more and more offered endovascular repair compared to open repair. So we put 2 and 2 together. It should make sense that octogenarians should have an increased rate of complication. And that's what the authors meant to look at. So they designed this study collecting the data from 6 of those 10 centers, part of the US Aortic Research Consortium. All of these were physician-sponsored IDE studies. And the inclusion criteria, as Dr. Saqib mentioned, were all patients treated for pararenal or thoracoabdominal extent 1 through 5 in between 2012 and 2018. It means on fenestrated and branch EVAR. The only patients that were excluded were patients that presented with rupture. So the study then divided the patient population in 2 groups, octogenarians versus non-octogenarians. They stratified them by cardiovascular risk factors, including coronary artery disease, myocardial infarction, hypertension, hyperlipidemia, heart failure, COPD, end-stage renal disease, diabetes, and prior stroke. We also included history of active cancer, their ASA classification, and anatomic characteristics of their aneurysm. The devices employed for their treatment were either custom-made fenestrated and branch devices or the cooked P branch and T branch off-the-shelf grafts. And the follow-up included a 1 month, 6 month, 12 month, and yearly visit after the procedure. The study collected data for 893 patients, of which 22% were octogenarians. The two populations were fairly similar, although there was a statistically significant difference in the history of cancer with a higher incidence in octogenarians, lower incidence of hyperlipidemia, COPD in the octogenarians, and on average, they also had a lower ASA class. On the opposite side, octogenarians presented with a larger aneurysm. And this is the overall population table. You see that besides those factors, the two groups, octogenarians and non-octogenarians, are fairly comparable in comorbidities. Now, the most interesting findings of this paper, obviously these are data from highly skilled centers, so technical success was extremely high in both cohorts. But what is interesting is that the 30-day mortality rate in octogenarians was only 0.5% when compared to the 1.3% in the non-octogenarians. This did not achieve statistical significance, but it's still a good clinical indicator. Major adverse events were comparable among the two groups. Unfortunately, these were not subdivided, but included death, paraplegia, new dialysis, respiratory failure, and type 1 and 3 endoleaks were more prevalent in the octogenarian cohort. And as we said, these patients also presented with larger aneurysm on average, so that may be a confounding factor. And access complications rate was very low in both cohorts. Another clinically significant difference is the length of stay that was on average longer in the octogenarians group, although even this one did not achieve a statistical significance with a P of 0.2. On the late outcomes, both groups had a very high freedom from branch instability at 4 years, and related to this also freedom from secondary intervention. The 3-year survival nonetheless was lower on the octogenarian group, not surprisingly, when compared to the non-octogenarian. And here we can see on the Kaplan-Meier survival curve, the survival rate actually drops even more significantly after 4 years. Although when we look at the numbers at risk due to loss at follow-up, we have a very low number of octogenarians. So this Kaplan-Meier curve may not be as reliable at this time interval. So summarizing this, we see how these two populations studied at similar demographic and risk factors. And on average, the octogenarians presented with larger aneurysms and had more vessels treated and incorporated in their repair. And nonetheless, the mortality and morbidity rate at 3 years was pretty much the same in the two groups. So we can say from these findings that age alone may not be the best predictor of outcomes. And as Dr. Karkanayan demonstrated in his paper last year, sarcopenia is actually the stronger predictor of mortality in fenestrated and branch fever rather than age alone. And not surprisingly, we can say that open repair has a higher incidence of morbidity and mortality than endovascular surgery, especially in octogenarians. So this should push us to consider endovascular treatment in this patient cohort. In literature, there's some mixed results. In octogenarians, we can see the group by Dr. Long with Adrian Erthold in 2014 actually reported a much higher incidence of mortality in patients over 80 years old with a 9% versus 1.6%. Although this was not confirmed in other series, Estrenal in 2020 showed no difference at 5 years. Survival was obviously lower in the octogenarians, but her intervention and basal patency was comparable among the two groups. And Dr. Timaran already in 2017 presented a comparable incidence of postoperative complication, actually lower in the octogenarians group. We obviously need to take this study with some limitation. These, as I said, are patients treated in very experienced centers. So these results may not be generalized to the public once this technology becomes widely available. The mortality was obtained just based on death certificates and not by cause of death. So we don't know how many of those deaths were actually aneurysm related. And only ASA class and cardiovascular risk factors were considered, while preoperative functional status was not available during the analysis. And this may be a more important predictor of complications in this patient cohort. And again, the two groups, despite being very similar in risk factors and comorbidities, were not matched one-to-one. So this could impact our results. To conclude, we can say that fenestrated and branched EVAR is safe and effective, and early and midterm outcomes are comparable even in the octogenarians when compared to non-octogenarian patients. And we obviously need to look more into detail into the factors impacting long-term mortality when we prepare to address patients over 80 years old with fenestrated and branched technology. Thank you, everybody.
Alrighty, thank you. Great presentation. So I think we have a few questions from the audience. The first question is from Dr. Hingorani. And the question is, why do you, while there are some octogenarians who are reasonably healthy and good candidates, and there are some 50 years old who are too sick for a haircut, what are your thoughts about that? And how about nonagenarians?
Good evening. Thank you for having us here. It's a pleasure to join this journal club. Yeah, I think the goal was, we use like as a general rule, like before offering the repair, either for non-octogenarians or octogenarians, it's kind to have an estimate of about life expectancy. And even if he's not octogenarian, the patient is like too sick, not gonna have a life expectancy less than like 2 years. Usually we don't offer the repair. So I think that's the one of the baselines that we set up for to offer the repair. And I think the goal is not the goal of the paper was not like say that all octogenarians are good candidates for fenestrated or endovascular aortic repair, but to analyze and see if the age itself would be a contributor factor for those that we see and considered then suitable for repair.
Got it. Excellent answer. Let me ask you another question on the same topic. So as you mentioned that life expectancy is important. So age is age is a big number, but one could argue age is just a number. How about, other authors have used modified frailty index or other parameters of some objective criteria to determine the life expectancy. Did you consider doing an analysis based on their frailty index rather than just age?
Yes, I think one of the main would be a limitation we don't have. We'd like to go back and get some more information to the database. For example, as was mentioned about the sarcopenia study that was done by a single center experience. We could try that to expand to the consortium data but we would have to go and get all the measurements preoperatively and look at the psoas muscle area and trying to stratify based on that too. But I agree with you that a more objective data in terms of a functional status would be probably more another big important information to compare in between groups.
Got it. Dr. Abai has a question, and he asked that should this procedure be even offered to nonagenarians? And why do you think nonagenarians did better than octogenarians?
I think I misunderstood what they meant. It's non-octogenarians, not, they didn't offer it to 90-year-olds. I misunderstood that part of the article, but go ahead.
Oh no, I would just mention that we offer usually, except to young patients that are good candidate risk, we also offer as other centers like open repair also, and then we don't exclude based on only the age.
Got it. Dr. Humphreys has a question, and she's asking, do you think there's a selection bias in the paper is why the outcomes are so good in the octogenarians?
Yeah, that is a implicit bias based on if it's a patient like it's too sick. It's we discuss the risks and benefits, and so which is hard to eliminate this bias in a surgical population, especially octogenarians. So yes, I just don't know how to explain how much this would impact the results, but I think it's a combination of factors. It's a natural selection bias. I think those procedures are performed in centers of a high volume with very experienced surgeons, so with improved access to good technology, that it decreases operative time, blood loss, and then those are also some factors that I think impacts the outcomes.
Got it. Dr. DeMosia has a question, and Dr. DeMosia is asking, what calculator do most people use to determine life expectancy?
We don't use any specific calculator. We know that we have the SVS calculator for a more complex aorta, but I think we also analyze depending on how extensive is that aneurysm, how many vessels are going to be incorporated, how much aorta you're going to cover, and then it based more on the comorbidities. We kind of look at the recent benefits, what the risk of the loss of renal function and early complications and late is it's kind of patient based. We don't have this any tool like that to put all the patient comorbidities, age, and then kind of discuss what would be the risks.
Got it. Dr. Glovitsky has a question about the location of the aneurysm. Did you do a sub-analysis for type 1, type 2 versus suprarenal aneurysms?
We did. That was one of the questions of the reviewers during the submission, the paper submission. One of the reasons we clamp it together, type 1 to 3 and 5, is that those aneurysms, we necessarily has to cover more than 5 centimeters above the celiac arteries, and this is one of the main factor related to the AR, the post-op complications, especially spinal cord ischemia, and that when we do the analysis separately, based only on aneurysm, we did not found a difference by each type of aneurysm. However, some of those aneurysms that were less common, the standard error of the curve would be more than 10%. So that's why we did not include these curves in the paper, because would be not the sample size would be too small by each aneurysm.
Sounds good. In the interest of time, Dr. Schneider, any final comments from you? And I believe Naveed does have a question for you in regards to any increase in the use that you've seen in octogenarians based on the data submission to FDA?
Yeah, well, first I want to thank Paul and Misty for the invitation. I think that this has been great. And I think Fernando, did really the lion's share in the heavy lifting and putting this paper together, and really should be congratulated on that. And I think just touching on some of the questions, I think first and foremost, I think it's absolutely striking how low the in-hospital or 30-day mortality is for fenestrated and branched EVAR, even in octogenarians, when you compare that to the results, the best results that have ever been published with open surgical repair. And this is from prospective studies that are IDE studies with oversight and monitoring. So I think it's really incredible data, and a credit to what the group has accomplished and what may be possible now with endovascular. To Misty's question about selection bias, of course there's a selection bias, and there should be. We shouldn't offer complex repairs like this to every octogenarian who walks into our office. We have to use some judgment and try to offer it to patients we think are going to benefit. And we do need to be better in terms of identifying that, but at least it seems that that we're able to do that fairly well, and that our results were pretty well matched between the octogenarian and the non-octogenarian groups. So, part of it is frailty assessment, the eyeball test. That's all part of what we do when patients walk into the office. I definitely do it. And I guess there was one question, are we doing more octogenarians now? I think I've been seeing more octogenarians. So I think that as a function of that, I treat more octogenarians. It does give me a little confidence to know if we pick the right octogenarians that we can get good results. And just, one more thing getting into the data. So now that our data set has over 1,600 patients, I know that Gustavo is working on a description of the results, and it's almost 1,700 patients. It's fairly remarkable. And we are presenting some data looking at reinterventions and the effect of a requirement for reinterventions, what effect that has on long-term outcomes. We'll be presenting that at VAM. So I think that's very interesting, because that's been one of the main criticisms of endovascular approaches, is the need for reinterventions. And I think finally, when you kind of compare this to, like Naveed said, Houston, Caselli with his publication of over 3,300 open thoracoabdominals with actually remarkable results. But if you look at his publications and his results specifically in the octogenarian population, I mean, you're looking at overall all octogenarians, including the type 4s and everything, at a 30-day mortality of 14% in the best hands for open surgery. So I really do think that endovascular is hopefully fulfilling that promise, that maybe with a less invasive procedure that we can treat some of these patients and lessen some of the impact and morbidity and mortality.
Well, thank you. Thank you, Dr. Schneider, for sharing your thoughts. And thank you to our special guests, to our authors for being here, for our host institutions from Case Western and from UT Houston. It was an eventful session. It'll be hopefully less eventful in September. But we definitely appreciate all the conversation. I think you can all read Dr. Conway's question in the chat. That's the last one, just asking about should we be setting limits? And I think it's something for us to think about. But I do think that these papers gave us some information about the extremes of what we can do, and selection bias, as Dr. Schneider mentioned, plays a big role in treating some of these older patients. And I think maybe in the future, we'll see other things coming along to talk about appropriateness, which we just had the town hall on appropriateness in other arenas. So we appreciate everybody being here. We thank you very much. Look for information about the September Journal Club, and we will see you all again.
Thanks all. Thank you, Misty. Much appreciated.
Great work, all of you, especially the residents and fellows. Great work.
Great job, everybody.
Yeah, great program. Thank you.
Thanks, Peters. Appreciate it.
Thanks, guys.
Thanks, Misty. Thanks, Paul.
Have a good night.